So it's my pleasure to introduce Dr. Amr Sallam here, my colleague in Ireland. He is actually a lecturer in Ain Shams University and was a neuroanesthesia fellow in Beaumont University Hospital in the last year. And so he is combining between the Irish experience and Ain Shams experience. And when he talks about neurosurgery, that's the area of his expertise and his interest. Most interested in neuroanesthesia. So when we are talking about complex spinal surgeries, he's one of the right persons to talk to you about that. So, Dr. Amr Sallam, please go ahead. Thank you.
Thank you very much, Dr. Walid. Thank you very much, Dr. Salwa, for the nice and lovely presentation. Thank you, Dr. Samir, as well, for your moderation. We're going to talk today about anesthesia for complex spine surgery. And here, complexity in spine surgery is a relative term. What is complex and what's not? But like we can conclude that any revision to prior back or spine surgery might be complex. Scoliosis surgery or corrective surgeries is also, but we can conclude all that any type of surgery that involves any major deformities or major curvature correction or spinal tumors or trauma. Stanford University Hospital developed this classification for its own practice, just to determine what IV access, what supposed to operative destination the patient would be sent, and it shows each and what the estimated blood loss as well. It's not recognized, but I find it very nice and clear, and it clears everything for us. When we gonna discuss about any patient and we prepare our patient for the surgery, especially complex spine surgery, we mainly, I think, about three main points: pediatric and for adolescents. Corrective surgery is the commonest with the scoliosis, which is with the respiratory and cardiovascular sequelae and effects on this whole system, or either spina bifida correction with the autonomic dysfunction and autonomic dysreflexia that will happen. While in adults, we expect more like an autoimmune diseases like rheumatoid arthritis, or even a degenerative disease like osteoarthritis, that with all of its sequelae and all of that affection of the old age people involved in that systems. While if we talk about the surgical approach or the level of the involvement of the surgery, so I think just it will jump to you, like if you are discussing a cervical surgery, so intubation is a very critical importance here, has a very critical importance, and has to be discussed and planned as we will talk. And the involvement of the Graves vessels and the nerves and the delicate structure in the neck, if we're approaching that from anterior. While in thoracic surgeries, most difficult thing is the ventilation. Is it a one lung ventilation using a double lumen, or just a one lung ventilation with a simple tube and a little bit of pressure that we require more inflation? And positioning as well, either it's lateral or an anterior approach or a posterior approach, or alternating, which is a major thing and has to plan, and we have to plan that for weeks and to train the whole team for that. And for lumbar procedure, I find the most critical thing is proning, and we will talk a lot about proning in this lecture because it's one of the most critical things. And then the last thing is any specific monitoring required. I'm talking here about the invasiveness of the monitors. Is it like a cardiac output monitors? Arterial blood gases is something like a standard now for the whole complex or major spine surgery. But neuromuscular monitoring is evolving. It happens a lot with a lot of surgeries, not either the scoliosis or corrective surgery. We had loads of surgeries that required neurophysiological monitoring, and that will require some specific consideration in our anesthetics. So let's discuss about the patient and what we will prepare, how we are preparing this patient, and what's the preoperative optimization. And I'd like to discuss that in a major 5 points. These 5 points have to be reminded, and I remind them like that. So first of all, it's airway evaluation. Airway management for these patients presenting for spine surgery, specifically, of course, cervical or upper thoracic surgery, should be planned well. The patient should be examined promptly, and the patient may present with a disease or that destroys the airway itself, like rheumatoid arthritis with involvement of the jaw movement or the neck itself. Rheumatoid arthritis need to be a cervical surgery, but you still have to be considering a lot about the whole airway and the whole how the planning is for that. The other thing is the pulmonary evaluation for these patients. And pulmonary evaluation for this patient, our minds will jump directly to the COPS angle for scoliosis, but it's not the only thing. Assessment for pulmonary evaluation for these patients is very important, especially for a kypho and scoliotic surgery, because that might lead to some sort of restrictive lung pathology, and that will subsequently lead to cor pulmonale and pulmonary hypertension. But still, other diseases and old age as well might present with a COPD or a Kaplan nodular rheumatoid arthritis affecting the lungs as well. All of these might lead to some sort of complications through the pulmonary system. It must be evaluated. Pulmonary function testing and arterial blood gas analysis as well should be considered, especially in thoracic surgery if we are planning to one lung ventilation. Do we think that the patient will tolerate one lung ventilation or not? And that will predict the effects of the one lung ventilation and thereby the surgical approach. We might decline a lateral approach or a thoracotomy for a patient because they don't have any pulmonary reserve. Cardiovascular evaluation for scoliosis with the pulmonary hypertension and cor pulmonale. But systemic hypertension, rheumatoid arthritis might cause some sort of heart block as well. The other tricky point in these patients that these patients presenting for spine surgery usually are unable to exercise and cannot provide any proper functional assessment. So most spine surgery as well is performed in a prone position, which is associated with a reduction of cardiac index between 12 to 24%. Compared with the spine. That's a result reduction of the venous return and the left ventricular compliance. The last 2 points in preoperative evaluation of these patients in the musculoskeletal evaluation and the neuromuscular evaluation. And these are very important because we are presenting to elective case, hopefully. Trauma, yes, it's emergency or urgent, but like we still have time to evaluate our patients. Some of the patients having spine surgery have coexisting conditions that make surgical positioning challenging, and we have to plan that. It's not a very easy thing to present during the surgery. You are able, the patient has a limited shoulder mobility, and you are not able to put him in a prone with his hand beside his head. That may make a lot of things difficult, and you have to assess that as well. And the neuromuscular evaluation, it's mainly for the anesthetist safety. Existing motor and sensory neurologic deficit should be recognized and documented prior to the surgery. Knowledge of the existing deficit will give, especially after intubation in a cervical spine instability, for example. Then after we finish the evaluation, now we are for the next step, which is the lab investigation. And existing comorbidities and invasiveness of the surgery that will help and should dedicate the preoperative laboratory evaluation you are. And then the most important thing I think about is the pre-medication itself. And that will lead us to the first question. What do you think about what's on the best evidence, which is the pre-medication you would suggest for an ACDF, which is an anterior cervical disc fixation of 3 levels, which is a major surgery? Is it a 5 milligrams of midazolam, 5 milligrams of morphine, a hyoscine patch, an oral pantoprazole 40 milligram, or an oral gabapentin? Yeah, so it wasn't a conclusive answer, and I totally agree. And like according to the best evidence, gabapentin is the only the medication that's proven that has an efficiency for post-operative pain for and the opioid consumption. We have been using midazolam and morphine for the stress of the patient and helping, but that might hinder their pulmonary functions if there is any some sort of restrictive pathology. While for hyoscine patch, if you are planning for an awake fiber optic, yes, that might be helpful. Other than that, it won't be any useful. Actually, the last two, that's the one I used to use. The gabapentin is mainly with the evidence that will be shown now This is a meta-analysis that's published in 2017 about the efficacy of preoperative gabapentin, which is a very nice, and it shows like about 10 trials involving 800 patients. And all of the studies suggest that administration of gabapentin is effective in reducing postoperative opioid consumption and the VAS scores for pain scoring, and even the some side effects of the spinal surgery itself. While this meta-analysis, the network meta-analysis, is to assess the dosage itself. It varies between 300 and 900 milligrams. And the end result is there's a dose response relationship curve. So however you can be able, but like tell the patient to tolerate, because they have some side effects as well. I prefer like 600 milligram, which is the midway between 300 and 600. Some of my colleagues would go for a 300, but like it's very rare if we go for the 900 milligram. Then we finished, our patient is in theater. Now we have to think about four things. These are the four critical points in anesthetic plan we have to think about. First of all is the airway management. Airway management in these patients, and I cannot strain on this point more. These patients require prompt planning to choose the technique which suits the patient, your expertise, and the facilities you have in the hospital. And some hospitals, and my hospital was one of them, has developed like a protocol to take a decision about these plans. And this is a very simple protocol. In fairness, it depends on two main points: about the stability of the spine, and the risk of aspiration. And it starts between using the non-depolarizing muscle relaxant, or even going up to awake fiber optic, passing through the intubating LMA and sleep fiber optic as well. The other point is the positioning. And the patient position for spine surgery depends on the spinal level. For upper cervical, for example, we might use this on the top right corner, which is the Mayfield, which is, I find it more stressful and causes more pressure, blood pressure rise in the patient if you are not careful about that, more than the surgical incision itself. Or even using a roll beside that and leading to extension of the neck. We should be caring about these points. And for thoracic spine, for sure, is the anterior approach, which is very rare now. We prefer using the posterior approach and lateral approach. I might not go through the whole risks of all these approaches and what's the nerve injuries possible, and what's the lesions, and what's the causes that will lead to that. We'll discuss more about the prone position, and I'd like you to ask you about the question about the prone position to see how we aware about that. It's which is most correct about prone position. Proning has always improved ventilation, perfusion matching. Prone position poses higher risk of nerve injury than the supine. Cardiac index improves by proning, which improves the VQ matching, or the jackknife prone position has less bleeding risk than prone position. Yes, I know it was a tricky question. In fairness, the right answer is D, and we will talk to that. Proning position is not always improving ventilation perfusion matching. Some of patients we have, even in the COVID or outside the COVID, might lead to hinder the ventilation perfusion matching, leading to hypoxia in some patients. And prone position doesn't pose any high risk for the nerve injuries more than supine. There is no evidence against that at all. And we discussed about the cardiac index that improved the proning. Actually, proning hindered the cardiac index by 12 to 24%. And we'll talk about the study that reveals that. Jackknife prone position is the proper position that we consider, and that will be shown in the lower left. And that is the proper position for a lumbar disc now, for a single level or more even. And we have a study for that. We'll talk about the less bleeding. That because it's lead to less abdominal pressure and compression. So let's talk about the prone position a little bit and about its effects. It's a common position, and it affects the whole system. We are aware of, all of us, about the respiratory effect and its outcome and improvement of the VQ matching, helping with ARDS and all of that. And that the pathophysiology is a little bit tricky. We were depending on the gravitational theory that explain the improvement has been proposed and suggest that blood flow favors to go to the dependent area, which is a more better irrigated area now. But this study in 2010 was published, and they used an isotope scanning, CT scan for the lungs, and they showed that there is no change in the distribution of ventilation, but more, it's even distribution of the pulmonary blood flow, and that will lead to some sort of improved match sheet. So it's not the gravitational theory we can follow, it's challenged now, and there's a model based on the branching architecture of the pulmonary vessels and the airway has been recently proposed, and that provides an alternative which is more or less accepted than the gravitational theory now. For cardiovascular, yes, it's the effect of prone position. This is a study was published 2006, and it's talking about the hemodynamic effects of the proning. And everyone has done a proning before, knows that the blood pressure will drop at this specific moment while we are proning the patient. And the cause for that might be the decrease of the LV compliance or the compression and the decrease of the preload. We are not so sure about that. It's not that clear yet for all of us. Cerebral blood flow, it might be hindered by the tilting the head to one of the sides, and we used to use that a lot to tilt the head, and we are aware about that congestion of the internal jugular leading to tilt or kink in the internal jugular with the tilt of the head. While the renal effect, they mentioned in a small study, including 82 patients, we're talking about improvement of renal blood flow to the kidneys as well. And talking about the other side, which is the complication of prone position. And this is a very nice systematic review discussing only the prone position. And surprisingly, they included about 53, and the most discussed complication of prone position was the post-operative vision loss, which is a very rare, it is a very rare complication. But it is very devastating as well, and we will discuss that in a moment. But other than that, the commonest to happen is the cardiovascular compromise. These are the most common, while as we said, the nerve injuries in the prone position is as well as supine position. And there's a study suggesting that even in the surgical nerve injuries is equal to the medical nerve injury. So the patient who's admitted either surgical and medical, they have the same risk for the nerve injury, so it's not more for the position itself. And that's what we were talking about the jackknife positioning of the head, of the whole body, and that affects, it decreases, and they concluded at the end that it decreases less intra-abdominal pressure elevation and less surgical side bleeding as well. So, and they concluded that the jackknife position is the preferred choice. I know a lot of surgeons now is performing the single level and the multiple level in the jackknife position. Now, let's talk to the commonest mentioned complication. It's not the commonest, it's very rare. It's the incidence is 17 in 10,000 up to 1 in 1,000 in whole assessment. But it is very devastating. It is very scary for the patient and for the anesthetist as well. The major cause of the vision loss in the patient population includes either ischemic optic neuropathy or central retinal artery occlusion or retinal vein occlusion. And actually in the United States in 2012, they developed a group to study in the whole registry, on the whole American registry, and they searched for the all variables in all patients, and they concluded that there is some variables that may lead to increase the incidence of post-operative vision loss. So the non-changeable is that the male patient's higher risk, the obesity, and the patient with diabetes. But there's other factors that can be changed, which is the anesthesia duration. That's something, and estimated blood loss. And Depending on that, they concluded the blood pressure drop and the requirement of more fluids. And that's what we are talking about. So in this position, and you can see the difference between both, we'd rather to keep the head at the level of the heart, and that we will come to these recommendation afterwards, rather than lower in the heart or higher. That's the safest way to keep the head, to avoid decrease the risk of postoperative vision loss. So coming back to their recommendation, and they ask for precautions to be taken. They have a very low grade support, evidence support, but still, and what they ask is simple things like head position at the level or above the level of the heart, use of colloids and as well as crystallized to maintain volemia, and maintain to the blood pressure within 20% of baseline. Anybody working in neurosurgery or in an orthopedic with a spine surgery know how important, and we will discuss that and we'll mention that frequently in fairness, and about maintaining the blood pressure in the same as the normal when he's awake. Monitor the hemoglobin and try to replace it if there is any significant blood loss. And the other thing is staging of long procedure when it's possible. So coming back to the other intraoperative complication that we will discuss, and we've gone through that, and we'll discuss the monitoring within them. So first of all, I'd like to talk is the spinal cord injury. And spinal cord injury is very uncommon. It's about more maximum, it will be 3%. The most important points we need to focus, it's not limited to the site of the surgery. It might be due to the poor positioning. It might be due to the low in blood pressure for a longer time. It might be at any level. And paraplegia, quadriplegia has been reported as a result of poor patient positioning. There are reports of patients with spine disease who suffered even injuries very far away remote, and we cannot attribute it at all to the surgery itself. If we kind of take a look about the blood supply here, and we see that the major vessel, which is the artery of Adam Wicks, and still the segmental arteries from the thoracic and lumbar region, these are very important, and we have to know about this. And they discussed about risk factors, and one of the risk factors I'd like to show to you is the sublaminar wiring and using of certain instrumentation, which is called loop rod. And that's what I encourage my junior colleagues to be involved. And I know most of the senior colleagues are doing that, is to be involved in the surgery. They know the steps, they know what is going to be used and everything as well. On the other hand, you have to look to that and to see that conditions increase the risk is induced hypotension as well, or inadvertent cord compression by the surgeon or by some sort of instrumentation as well. And in Toronto University, they developed and published this in 2008, and this is talking about the perioperative spinal cord injury. And they outlined the treatment and management. I'd like to point to some points. The first point still is to maintain the mean at 80 millimeter mercury. We have a specific number, but we still stick to 10% of the individual. If we have a younger patient, but like we prefer still to have a higher one. A higher MAP is very favorable for these patients. Using of steroids it's not concluded, it's not proven, but still they recommend to do that and to take the precautions. And they ask for and they added the need and the requirement of monitoring, either with the somatosensory evoked potential and motor evoked potential as well. And they outlined the treatment if that happens. And again, the recognition is the first thing, and to maintain the main. And I cannot strengthen more and focus more about the requirement of keeping the blood pressure above 80 in these cases when it's confirmed using of steroids. Yes, still some of the surgeons are still using the CSF drainage, and others will go for a systemic cooling, but all of these are not unproven, and they have a lot a lot of complications and side effects that will encourage us to go for that one. So I'll ask you another last question about the somatosensory evoked potential itself and the whole neurophysiological monitoring. And we are all aware about the effect of anesthetic on these neurophysiological monitoring. But what do you think has the least effect? Is it ketamine, fentanyl, propofol, barbiturate, or nitrous oxide?
Okay, you have the results on your WhatsApp.
Oh, that's a good answer, yes. The most is answering about fentanyl, and which is the right answer. Actually, ketamine has an effect. We don't know if it's a simulation or inhibition, but it's sometimes these. And we're gonna discuss why we are talking about ketamine. While propofol as well, it has some effect, but we have some sort of control about these. And barbiturate and nitric oxide as well has some effect. So the fentanyl is the right answer. So let's discuss about the neurophysiological monitoring. And once we mention that, two things that jump to my mind. First of all is the bile block. It's a very critical. It's a very important. Some authors would suggest bilateral bile blocks to be kept in the two molars just to avoid kinking of the tube. And the other point is to try to clear the body from muscle relaxant. We are not meaning to discuss rocuronium here, but yes, please do not try to clear the body at this point. You can use it earlier, but then you have to be sure that we are clear on board from the muscle relaxant. Types of neurophysiological monitoring, and its function is to assess the integrity of the structure of the neurons itself and the whole neurological pathway. We have a different types, and every type will measure specific areas in the neural system. So, for example, the somatosensory evoked potential will check the whole afferent neurons coming from the body to the brain and to the spinal cord, while the motor evoked potential is the opposite way, measuring the EMG as well. It's sometimes be used to assess the junction in the neurons between the neurons and the muscle, while the brainstem and the transcranial is not used frequently in a spine surgery. It's used more in brain surgeries. And if we're gonna talk about the somatosensory evoked potential, so the goal of the whole intraoperative neuromonitoring is to identify disruption in the nerve signals quickly so that surgical adjustment can be made before the spinal column configuration is set. Specialized spinal cord function monitoring can be achieved measuring evoked potential. One of them is somatosensory. And satisfactory monitoring of these is possible still with a MAC between 0.5 and 1 in isoflurane, desflurane, or sevoflurane is the most common method to use. And the most important thing that is a reduction in the amplitude of 50% or increase the latency by 10% would be considered significant, and we have to mention that. It's affected by the temperature. It's affected still by some of the anesthetics. We're going to discuss that in a moment. But we have to focus about this point. Post-operative neurological deficit can be found, can be reported even the normal of SSPs. And that is very rare. But that's what leads to development of the motor evoked about the motor evoked potential. If we're still talking about the somatosensory, that generally affects the intravenous effects, is generally affecting the somatosensory, but less, far less. Ketamine and etomidate increase the cortical somatosensory amplitude, while nitrous oxide. We'll jump to the next slide showing the effect of the whole inhalation anesthetics, the first three, and how they are affecting more than the propofol and the benzodiazepines, but while the whole opioid doesn't have the effect at all. And that's what causes us to tend to use more of opioid anesthetics in this, using remifentanil infusion, for example. And the motor evoked potential is the same thing, but inhalation anesthetics inhibits the myogenic MAP in a dose-dependent manner, while moderate doses up to 50% have been successfully supplement other agents during the MAP monitoring. So we can some sort use the inhalation. We are not preferring that. We are trying to avoid that the maximum. But if we are stuck, we can use that, and we are in some situation. The next complication we're gonna discuss is the intraoperative blood loss. Significant blood loss and complex spine surgery is something common. Some of the studies mentions up to 2.8 liters of blood being lost as an average, which is a scary number, but still might happen. And we are aware about the blood transfusion complication, either immunogenic or not, or infectious, but we're definite just to mention that blood transfusion may be associated with increased risk of postoperative infection. And these patients have high other causes, like a huge incision that might be involvement that will lead to that risk. And we are trying to avoid risk of the nervous system by any means. And just and that's to mean as well, the blood transfusion has a cost on our system, on our health system. We are coming from country that we work in a country that health system is not properly funded yet. So the cost of blood replacement must be considered. And in a recent cost analysis, a benefit analysis study, the average cost for cell saver was about $512, while auto transfusion is replacement up to $250. And just to discuss, some group tried to develop a predictive module for who patient will receive the blood and need to proper investigate his blood. And they reached that the age group more than 50 with a lower hemoglobin, which is accepted. But a transpeduncular ostotomy has the same scoring number with all of the other criteria, which indicates the importance again of being involved in the procedure itself. Now, for the last for the question about the conservation of blood, we go for that, and which intervention helps in blood conservation? Is it aprocitenine, magnesium sulfate, regional anesthesia, or controlled hypotension, or epsilon aminocaproic acid? So the magnesium sulfate is the right answer. We cannot prove, and I have seen that the maximum answer about the controlled hypertension. We are not using a controlled hypertension. Doesn't have any proven evidence about the benefit of the patient. And it again, we are trying to avoid the blood pressure at the high level. Epsilon aminocaproic acid has still a controversial studies and it doesn't, but the magnesium sulfate in fairness has shown the benefit about that. And that was answered in this article published that's published in 2010 about the blood loss. And they discussed the whole way and they studied the whole other ways. And just to go through them. So discontinuing aspirin doesn't have any effect about the bleeding. In contrary, all the surgeon would ask the patient sometimes, but like if patient on aspirin, please don't stop that. Erythropoietin might cause some reduction in the requirement of blood transfusion, while autologous predonation doesn't have the same effects. About the intraoperative pharmacological antifibrinolytics, use of the antifibrinolytics, and I hope we are all aware about the CRASH-2 trial and CRASH-3 trial and how the benefit of the tranexamic acid is used for the reduction of the blood transfusion. It's one of the proven with the high evidence supporting that. Magnesium sulfate, although it has a moderate level of evidence, but it still shows some sort of that. Regional anesthesia-induced hypotension is very low, and optimized prone position as well, as was shown in the jackknife positioning study, shows the same answer. And intraoperative blood salvage. And the surgical technique and the staging of the operation has proven to be helpful as well, with a very low evidence. The last question for the last important and very important, sorry for that, Walid, I know I'm a little bit late, about the post-operative analgesia, which is a very critical and very important as well, with some points. So paracetamol has proven analgesic effect post-operatively, and a non-selective COX-2 inhibitor has more potent effects than selective. Preemptive analgesia using gabapentin has proven post-operative analgesic effect, or local anesthetic infiltration is the most effective analgesic intervention.
5 more seconds.
Yes, we're getting a right answer now with the 50% still. I know it's a little bit conservative. It's a little bit difficult to answer, but prove paracetamol till now, and this is one of the questions that I still have in my mind. I cannot answer. There is no studies. Studies try to prove that, fail to prove his efficacy, while non-selective COX-2 has less potent efficacy than the selective one. Yes, and preemptive analgesia. We'll jump a few bit slides about the antifibrinolytics, and we're going to discuss the analgesia for complex spine surgery. So, multi-level spine surgery might require very intense perioperative pain control. You don't like your patient to be converted into a post-operative pain, chronic pain patient. And there's a systematic review just discussing all of these points about what to use, and it shows it had included the whole trials. It's a very brilliant. It was published in October 2019 in the Current Opinion in Anesthesiology. And one of the things that I'd like to mention is one of these is the perioperative intravenous ketamine for acute postoperative pain in adults. I remember when we were discussing that we cannot use that with the neurophysiologic monitoring. Yes, and with these patients, we tend to use it after we finish and we confirm everything, or even in the post-operative period, because this is one of the brilliant systematic reviews and meta-analysis has been done, and it includes about 130 studies, with including about more than 8,000 patients, and it concluded at the end that post-operative and perioperative ketamine infusion reduce all the analgesic requirements and opioid consumption as well, and improve the outcome of these patients and the requirement of opioid and its complication. The last point I'd like to discuss is the extubation. Most common causes of admission for ICU for spine surgery is failure of extubation and requirement of ventilatory support. Airway facial edema is very common to happen during the long procedure with prone position, so that will be very difficult. And the incidence of airway compromise requiring re-intubation after anterior procedure, it might go up to 2%. You have to have a plan for the airway compromise, how to do that in a stepwise, and how to perform, and at which level you have to re-intubate and transfer the patient either to the operating theater or even for a tracheostomy for these patients to do that. Just to summarize at the end, airway management is a critical point. Airway planning as well for these is very important. Anesthetic agents and neuromuscular blocking affects neuromonitoring in some controlled way with some medication, but we have to consider that as well. Blood loss may be significant or even massive for some spine procedure, and you have to think about planning and plan for the blood conservation and the blood transfusion as well. Positioning, and care about every single step in positioning your patient from head to toe, from abdomen and for his chest. And the post-operative visual loss is important, a rare, a devastating complication. It might happen to any of us, so we have to take a good care about that. And thank you very much, Walid.
Perfect. Thanks so much, Dr. Amr. Allow me, first of all, to express my warm thanks and sincere gratitude for all our colleagues sharing with us today their expertise and knowledge. Prof. Salwa Al-Khattab and Dr. Amr Sallam. I will put the first assessment of the first lecture here now while we are running a few questions with Dr. Amr. So this is your assessment and attendance sheet for the first lecture from Prof. Dr. Salwa Khattab. And the first question, Dr. Amr, is gabapentin is continued post-operatively or only just single dose in pre-operative, and that's one dose only?
The network meta-analysis discussed only the single dose, while other studies discussed it using preoperatively. But we prefer to continue on that post-operatively as well, and there is no significant, there is no important studies has been discussing this point a lot, because that will lead us to a lot of statistical problems. But in fairness, in my institute, it's a protocol to use a gabapentin preoperatively and postoperatively as well for about 3 days.
Perfect. So another question from the same colleague. Recommendations before wake-up test. What should you do before waking up the patient for wake-up test?
Wake-up test, we didn't discuss that. Yes, wake-up test is the oldest and the surest test to test with that. The first point, you have to discuss that with the patient. This is this is the first important and critical point. You have to explain to him every single step in the preoperative assessment clinic and in the morning of the day. So, and you are clear about there is no, and the neurophysiological and the neurophysiologist will clear that we are no muscle relaxant as well, and then we'll start to awake the patient, and we prepare him before that about which limb he will move, and we'll ask him to move his limbs, and then we'll give him some sort of we'll start again the anesthetics. And use that. But the most important thing is to discuss that to the patient and to explain to him. That's very clear as well.
Perfect. So I have 3 questions I will put all together here. They're all about pain management. So what's the dose of magnesium sulfate and the protocol of ketamine infusion post-operatively? And is there any contraindication to use the gabapentin?
I'll start from the last. Yes, there is some sort of contraindication. Moderate to severe renal failure is considered some sort of contraindication. We can modify the doses. Suicidal attempts and myasthenia gravis, I think, is the contraindication, the clear contraindication. Other than that, there is nothing clear. About the magnesium sulfate, it's not clear, and a lot of people using different doses. Some will tend to go for 2.5 gram as a bolus during in the intraoperative period, just to help with the bleeding and the postoperative pain as well. And where some will recommend like a dose of 0.01 milligram per kg as a postoperative dose infusion with a close monitoring for the reflexes and the level. While the ketamine infusion, it has different models, and we go for 0.1 milligram as a bolus, and then starting with 0.01 milligram per kilogram per hour. That's over 16 hours as an infusion as well.
Perfect. So is steroids given routinely for prophylaxis for facial and airway edema?
It's not. I didn't. So what we're gonna use? We are not using that. Facial edema is something mechanical. We are trying to avoid that by mechanical. I don't think steroids will help a lot. I don't have any evidence supporting this idea, and I cannot explain, or I cannot rationalize that giving steroids to the patient for a facial edema that will take hours just to be resolved. I think we'd conserve the steroids for something more critical rather than the facial edema.
I have seen it used for airway edema in severe laryngeal edema post-operative, but in facial edema,
yes,
I didn't see
I
that
totally
before.
agree with angioedema or airway edema, yes, but like with a facial edema, just facial edema, we didn't try it.
Okay, what about lidocaine infusion for analgesia from your point of view?
Lidocaine infusion is controversial still. There's some evidence supporting that. Some of my colleagues are using that, and we are using lidocaine infusion for chronic pain. But to use it with the high concentration and the same doses we are using with chronic pain, that would be too massive, and that might be a little bit require every single patient to be monitored for a longer time after the post-operative period. and giving that with all of other, sorry for that, and giving that as well as a medication, and with no support, like strong support evidence to support that, I think it will be a little bit more aggressive as well.
Perfect. So we're going now for the second poll to assess the second lecture of Dr. Amr. So kindly start voting for that. And the last question is here by Dr. Hani Abdelgalil. Is there any value for acute blood loss for transfusion in scoliosis surgery? And what about euvolemic hemodilution and autologous blood transfusion? What do you think about each of these?
Can you repeat the first part of the question again, Waleed?
So is there any hemoglobin cut-off for blood transfusion in the acute blood loss setting in scoliosis surgery?
In fairness, I'd like you to ask you that, Waleed. We don't have a cut-off. Like, we have the restrictive people who would say, yes, we allow the blood loss to be 7, and I don't know why it's 7, why it's not less, why it's not higher than that, and 10. We don't have a cutoff. We depend more for the acute loss, to replace the amount of the blood. We have the maximum allowable blood loss for this patient, and we'd replace after that.
I think, Amr, like, it goes with the common sense, and be vigilant if the bleeding is like horrible and you can see that the surgeon is struggling to control the blood loss intraoperatively in a surgery like scoliosis. Don't wait until 7, because he will reach 7 sooner or later. So go for blood transfusion as soon as you can. But if the surgeon is confident enough that he's controlling the bleeding, which I don't think this is a scenario with scoliosis most of the times. So if we find a bleeding patient, don't wait for certain figures, just your hemovigilance, and it's all together. Like, you look at the hemodynamics. If the patient tachycardia, or you are on a high dose of NORAD or phenylephrine, this is the time you transfuse. Even your patient is not tachycardic, because you are blunting his sympathetic response for tachycardia. I think it's like there's no right or wrong answer or black and white in these regards. If you agree with me,
we'll try to be vigilant, as you said, and we are trying the maximum not to give the patient the blood. But at some point, we need that. With the scoliosis, with other surgeries, the bleeding might be so frank; it might be like more an ooze or something like that. And as you said, we have to use our common sense, and that's why we cannot use an artificial intelligence in our practice. Still, we are keeping that for the human. For the normal volemic hemodilution and the autologous donation, I don't think about it. The last evidence hasn't shown a massive effect about that. Preparing these patients for that with a cost which will cost more than €1,000, and we don't have the support evidence to support that. It's helpful. I'd prefer for myself, if I'm going to get a blood, to get my autologous blood. But still, you cannot consider that as a common practice or protocol in your institute, I think.
Perfect. So by this question, we ended the discussion, and we would like to close the session with Professor Dr. Samir Al-Ansari. And if Prof. Salwa wants to give us a word before leaving, she's the first time here with us tonight.
Thank you, Dr. Waleed. Thanks, Dr. Salwa. Thank you, Dr. Amr.
Thank you very much.
And highly informative 2 lectures. And I agree you, ketamine now is proved totally as a potentiating effect for opioid analgesic, and it is used to potentiate analgesia in post-operative period. Also, in addition, it has antidepressant effect, and may continue for 6 months, up to 6 months after just a few doses, 2 doses or 3 doses from ketamine. Really, thank you, Dr. Amr, for this.
Thank you very much.
Really, I'm enjoying with it, and Dr. Salwa lecture. Dr. Waleed, I think Dr. Salwa lectures needs to be divided into 3 lectures. To be
definitely. I didn't believe that it's gonna finish in 30 minutes or 40 minutes.
I was surprised Dr. Samir is telling only 5 minutes, almost half of
after pushing from Dr. Waleed, really, not from me. Thank you, Dr. Amr, for your
very much.
Nice lecture.
Prof. Salwa, do you want to give a word for the attendees tonight before leaving?
Enjoying very much these webinars. I'm thinking COVID put us to be online together so we can share our experiences and like that. And I need to confirm that success, I will be back to my topic, management of acute kidney injury is a multidisciplinary approach. Please keep a multidisciplinary approach, and I'm thinking we might have different, maybe another topic about that, especially in my colleagues' clinical pharmacy. Clinical pharmacy is adding a lot to my career, the discussion and everything. Thank you very much for making this arrangement, Dr. Walid and my professor, Dr. Samir. It's a pleasure and it's an honor to be with you. Thank you very much.
Thank you. Finally, I have a lot of requests here from you, Prof. Salwa. Please, we need another lecture from you. So I promise that there's 2 more lectures for Prof. Salwa. So you will see her again and again. See you next week, Saturday, 29th of August, 9 p.m. Cairo time in the 11th week. We'll keep you updated with the lectures coming all the time as usual. And please don't forget to visit www.savinglivesacademy.com to find all the previous lecture recordings, and keep in touch. If you have any questions, we can deliver always your questions to our guest speakers and professors. Thanks very much, and see you all back next week. Assalamu alaikum.